today I'm gonna present on antenatal care and gestational diabetes. So a little bit about me. At the moment, I'm working as a Trust F1 in Dorset County Hospital. I graduated from Semmelweis University from Budapest in Hungary, and I did my 6th-year thesis with the Public Health Department on the effect of social distancing on the spread of COVID and psychosocial issues as well. I did some research for a year and a half with the Institute of Enzymology in Budapest, where I got some pet mice from the lab as well, which was lovely. And at the moment, I'm also doing a master's in public health with King's College in London, with an aim of going into humanitarian work, possibly in pediatrics. So, talking about an obstetric history. So, first of all, we need to know about some key pregnancy details. So we need to know about how many times this person has been pregnant for and how many children they've actually had, because sometimes that can not really be the same number. Some people might be pregnant more times than they've actually delivered a baby. So we need to ask about the presenting complaint and also the history of the presenting complaint as well. And we need to talk about some obstetric symptoms, which we'll talk about in the next slide. And then we need to think about, need to discuss about the ideas and the concerns and expectations from the consultation, and then summarize what we've discussed with the patient at the end. So obstetric symptoms, can anyone come up with any obstetric symptoms? If you just type it in the chat. Yeah, PV bleed. Anything else? Yeah. Abdo pain, yeah. Yeah, really good ideas. Anything else?
خلي علاش جوج الناس كيشربوا من after no.
Yeah, reduce fetal movements. Yeah, these are really good. Okay. So most of this is there. So nausea and vomiting, reduced fetal movements, vaginal bleeding, abdominal pain, discharge, headache, visual disturbances, pruritus, and all of this. Right. So if a woman came in with nausea and vomiting, did you what sort of questions would you ask about this? Last period, yeah. Yeah, excessive vomiting, dehydration, yeah. Yeah, exactly. So what do you call it if someone has got excessive nausea and vomiting that's causing dehydration, and she's just very, very tired and fatigued and not able to continue with her, yeah, hyperemesis gravidarum, yeah, perfect, really good. Really good. So if there's reduced fetal movements, what would you suggest to the pregnant woman at that point? Because obviously the mother knows what is normal for the baby, and if she just comes in saying like, I don't think my baby's moving as often as it normally is, what do you think you would do? Yeah, ultrasound. Yeah, exactly. The baby might just be sleeping. That is, yeah, really good. So the baby might just be sleeping. So you might ask her to take a really cold drink and just walk around for a little bit and see if that helps. But yeah, if not, then you would do an ultrasound. You can do a CTG to see the heart sounds of the baby. Yeah, really good. So For vaginal bleeding, yeah, abdominal pain, that's kind of, we would go through the Socrates method, the site, onset, all of that stuff, the timing, when it started, does it radiate anywhere, all of the normal pain questions. And so if a patient came in with headache, visual disturbances, epigastric pain, and edema, what's the first thing you might think about? Yeah, preeclampsia, awesome, really good. So if a woman came with pruritus, what do you think is the cause of that? Yeah, cholestasis. Awesome, you guys are really good. And if there's unilateral leg swelling, what do you think? Yeah, cool. And what was the blood test that you would do for a DVT? D-dimer, awesome, really good. What about if there's chest pain and shortness of breath? Fairly similar, yeah, PE, really, really good. And then just normal symptoms like fatigue, fever, and weight loss as well. So the point of antenatal care is just, it's the care that pregnant people receive during the pregnancy, and it's to check the health of the mum and baby. It's to provide advice for the pregnant person and discuss their options for what they have and answer any questions that they may have as well. So this is the pregnancy timeline. So before 10 weeks, you would just offer a baseline assessment and plan the pregnancy. And then afterwards, it's a dating scan. So this is for an accurate gestational age. And you look at that, the way to do that is by calculating the crown rump length. So that's from the top of the head to the bottom. And if there are multiple pregnancies, then that's when it's identified as well. So then afterwards, you would discuss any results from the dating scan and plan any future appointments there. And then afterwards, you might do an anomaly scan to see all of the different organs through an ultrasound and see if anything is not working as well as it could, or if there's any heart conditions, if there's any abnormalities there. And then afterwards, it's just monitoring and discussing any future plans. So if we talk about Down syndrome for a second, so Down syndrome is trisomy 21, so that means there's an extra chromosome on the 21st one, right? So you can do lots of screening tests for this, and you can do a combined test, which means the ultrasound and maternal blood test. And on the ultrasound, you will look for a nuchal translucency. So that's the thickness over here, like in the back of the neck at like 12 weeks. And it should be between 1.1 to 1.3 millimeters. And then you can do a triple test at 14 to 20 weeks. And that's when you do the BT-HCG, AFP, and serum estriol. You can also do a quadruple test a bit after that, which is the triple test and inhibin A. So using all of the screening methods and the nuchal translucency, you calculate a risk. And then if the risk is more than 1 in 150, then the parents are offered amniocentesis or chorionic villus sampling. Do you guys know what the difference is between those two? You can unmute yourself if you want to answer. Yeah. Do you know the technique, the differences in the technique? What is the difference between amniocentesis and chorionic villus sampling? Any ideas? No, okay. So amniocentesis is when you take a sample of the amniotic fluid, and the chorionic villus sampling is when you take a biopsy of the placenta. So that's the difference there. And now there's a new test, which is non-invasive prenatal testing. So that's when you can take some blood tests from the mother. And so there's no need for any invasive methods going on there, but that's still under progress and it's still trying to be made available in the NHS. And so there are some chronic conditions as well that you need to be aware of in the mother: hypothyroidism, hypertension, epilepsy, and rheumatoid arthritis. So if the mother has got any of these conditions, then the baby just needs to be monitored a bit closely just to make sure that everything's okay. So these are the different medications. Do you guys know what the harm is if the mother takes some NSAIDs? Yeah, patent ductus arteriosus. That's it. Yeah, great. That's really, really good. Yeah, and what about with opiates? Yeah, respiratory depression, but also when the baby's born, you can get opiate withdrawal in neonates. So that's really, really dangerous. So all of these are quite dangerous for the baby. So you need to ask the mother what kind of medication she takes and whether any of these are regular, and whether you can switch any of these to safer medication instead. So if we do the crown rump length to see the size of the baby, it can be large for the gestational age, and some of the causes of this can be because of maternal diabetes, which we'll get onto in a little bit. It can be because of maternal obesity or rapid weight gain. The baby can be overdue, and also a male baby can be large for the gestational age. So these are the risks, right? The risks to the mother are shoulder dystocia, failure to progress. You can get perineal tears during birth. You might have to use some instruments or perform cesarean. And you can also have a postpartum hemorrhage as well, and a uterine rupture, which is quite rare, but really dangerous. And the risk to the baby, you can get birth injuries, Erb's palsy, and all of this, fetal distress and hypoxia, neonatal hypoglycemia, obesity, and diabetes. Adult as well. So it can also be small for gestational age. So this means that they're below the 10th centile. They can estimate the fetal weight as well. Is below the 3rd centile. And there are lots of causes for this as well. For example, fetal growth restriction and intrauterine growth restriction as well. So these are the causes of the fetal growth restriction. It can be placental or non-placenta mediated. And so these are the causes of placenta mediated preeclampsia, smoking, alcohol, anemia, malnutrition, and there's lots of other maternal health genetic abnormalities as well, for having babies which are small for their gestational age, like smoking, diabetes, hypertension, older mothers, and multiple pregnancies and things like that. So let's go on to gestational diabetes now. So the risk factors here would be having a previous gestational diabetes, having a previous very large baby, having a very high BMI, and lots of ethnicities are more prone to having gestational diabetes, and also people with a family history of diabetes, especially a first-degree relative. And so this is how we do the diagnosis for gestational diabetes, an oral glucose tolerance test. And so you perform that in the morning after a fast, and they drink 75 grams of glucose at the start of the test. And then you measure the blood sugar before the sugary drink, and then at 2 hours. So the normal results are below 5.6 at fasting. Then at 2 hours, it's below 7.8. And so anything higher than this would be gestational diabetes. And so the management of this, so when you explain this to the mother and the father, so you need a joint diabetes and antenatal clinic. So you need, as well as the doctor, you need a dietitian and a diabetes nurse specialist maybe. And so they need to be explained about the condition and how to monitor and track their blood sugar levels and the amniotic fluid volume. And so the management of this would be, well, it depends on the blood sugar. So if it's less than 7, you can just try diet and exercise for a couple of weeks and then see if that actually fixes the problem, or if it's well controlled with this. If not, you can try metformin, and then you can try insulin. And then fasting, if it's above 7, you can try insulin and metformin. And then if it's above 6, but there's a large baby or other complications, you can try insulin and metformin. So you can also use sulfonylurea if the woman doesn't want to take insulin, or if they're just not really tolerating insulin or metformin, that's also an option. And so they need to monitor their blood sugar lots of times a day. And so these are the target levels. So fasting needs to be less than 5.3, 1 hour post meal less than 7.8, and 2 hours post meal less than 6.4. And then you need to avoid levels of below 4 because of hypoglycemia. For women with pre-existing diabetes, obviously they should aim for good glucose control. And it's the same target glucose levels as women with gestational diabetes, exactly the same as that. And they also need to have a look at their retinas just to make sure that everything's all right there. And so NICE advise a planned delivery between 37 and 38 weeks for women with pre-existing diabetes, and a sliding scale insulin regime needs to be done for women with type 1 diabetes during labor. And so postnatally, if women have gestational diabetes, it tends to just improve after birth anyway. And they need to be really aware of hypoglycemia in the postnatal period. And so the babies of mothers with gestational diabetes have a risk of developing neonatal hypoglycemia, polycythemia, jaundice, congenital heart disease, and also cardiomyopathy. And yeah, they need close monitoring for neonatal hypoglycemia. It's very important. Okay, so moving on to the case studies. Okay, so a 34-year-old woman is 9 weeks gestation in her 3rd pregnancy. Her first pregnancy ended in the first trimester suction at 18 years of age, and she had a miscarriage 8 months ago that needed evacuation of retained products of conception. So apart from that, she's quite well, apart from just mild asthma. She's got no family history of congenital abnormalities. She's a non-smoker, and before she was pregnant, she drank 3 units of alcohol per week. And her only medication was folic acid. Her partner was 31 years old and was adopted. He's got no known medical problems. And so the routine bloods and urine tests are normal, and the couple opt for Down syndrome screening, and the first trimester ultrasound appointment is booked for 12 weeks. Okay. So this is the report of the ultrasound. The single fetus, fetal heart to action is normal, crown rump length is normal, nuchal translucency is 3.2, the normal one is 1.1, and the risk of trisomy by maternal age is 1 in 276, but the adjusted one, taking into consideration of the nuchal translucency, is 1 in 30. So what are we concerned about here? Yeah. Yeah, so we're a bit worried about Down syndrome here. So how would you explain this report to the parents? What are the things that you need to include in the discussion with them? Yeah. What's the first thing you would say to them about the ultrasound report? About, like, we are worried about Down syndrome. So first we need to check that the couple understand what Down syndrome actually is. And we've already, someone mentioned that we should explain the nuchal translucency test. That's not a definite answer, that is just screening, definitely. So we need to explain what the nuchal translucency risk versus the adjusted maternal risk is. Yeah, like we said before, we need to talk about false positives as well. We also need to talk about the available options, about the chorionic villus sampling and the amniocentesis. Do you know why someone would choose to do chorionic villus sampling instead of amniocentesis? Yeah, both of them have got the same risk. There's a clue in the number of weeks that it's performed in. So the chorionic villus sampling is done a little bit before amniocentesis. Do you think that's got any significance about why someone would choose to do that over amniocentesis? No, okay. Yeah, exactly. So the chorionic villus sampling is done a little bit before amniocentesis. So if they were to consider terminating the pregnancy, if they really didn't want, I don't know, for whatever reason they wanted to terminate the pregnancy due to the risk of Down syndrome, then chorionic villus sampling would be a better option to do it a bit earlier than amniocentesis. Yeah, so then we need to explain how it's performed as well, and we need to explain the risk of miscarriage. And if they didn't want that, you can also avoid that and just do soft markers looking at the skull abnormalities, any ventricular megaly, atrial septal defect, duodenal atresia, echogenic bowel, hydronephrosis, and short limbs, which are all characteristic of babies with Down syndrome. But that's obviously not super accurate. So it turns out that the couple opts for amniocentesis, and this is the result of it. Chromosomal analysis, 46XY, normal karyotype. So what do we think about this? What are the next steps here? What do we think about the chromosomal analysis, 46XY, normal karyotype? What would you say to the parents? Yeah. Yeah, reassure them, definitely. So you might want to tell them to undergo some further investigation. So they've got quite a high risk nuchal translucency, but a normal karyotype. They've got increased likelihood of other structural defects such as congenital heart disease, exophthalmos, diaphragmatic hernia, and skeletal defects. So yeah, we can reassure them that like it's probably not Down syndrome, but there's a likelihood of other kind of anomalies there. So we would suggest for them to have a detailed anomaly scan and a fetal echo at around 20 weeks and keep going with that, because then we can do a full scan of all of the different organs just to make sure that everything is progressing as you would want it to. But yeah, some very good answers there. Number 2, case study number 2. So this 26-year-old woman attends a routine antenatal appointment, 31 weeks gestation. So she's had 4 pregnancies, got 3 children, which are all spontaneous vaginal deliveries at term. Her 3rd child is 18 months old, and the delivery was complicated by a postpartum hemorrhage, and she needed 4 units of blood. So this pregnancy has been uncomplicated with the normal booking blood tests, normal 11 to 14 week ultrasound scan, and normal anomaly ultrasound scan as well. But she's saying that she feels a little bit tired, but she says this is because she's caring for 3 young children. But there's good fetal movements there. What would you do? Yeah, that's really good. Everyone has kind of got the right idea there. Awesome. Good. Any more suggestions? Okay. Yeah, really good ideas, guys. So yeah, this is what we've done. We've done blood pressure, 126/73, hemoglobin, MCV, white cells, platelets. So what do you think about these results there? Yeah, there's a low hemoglobin there, and the MCV is also quite low. So yeah, microcytic anemia. Urinalysis was negative and white cells are completely normal, so that's absolutely fine. And blood pressure is also normal, so that's awesome. Yeah, so diagnosis, microcytic anemia. And yeah, I think a lot of people have caught on to is probably iron deficiency. So these are the implications of that. So for the baby, it can be really low birth weight. They can have neonatal anemia and also cognitive impairment. And for the mother, normal things like fatigue, fainting, and dizziness, but also peripartum, there's an increased risk of hemodynamic compromise. And so she might need more transfusions. So something to be aware of. Really good. Further investigations. So because we think it might be microcytic anemia, we need to get a full history to rule out thalassemia, but we also need to do iron studies and ferritin. And so low ferritin will confirm the diagnosis of iron deficiency anemia. We need to look at some folate, some urea and electrolytes, and liver function tests as well. And what do you think about the management? What would we do for her? Yeah. Yeah, so ferrous sulfate, 200 milligrams twice a day, and you can increase that to 3 times a day if she can tolerate it, because what's the really unpleasant side effect of iron tablets? Yeah, constipation. It's not very fun. As well as that, just iron-rich diet should be encouraged with green leafy vegetables. And she might need a transfusion if it gets very, very low. So during delivery, we need to be really careful because she's considered high risk for hemorrhage. So we need to make sure that she's got a wide bore IV cannula in there already. We need to do a group and save. And in the 3rd stage of labor, we need to have some active management there with an oxytocin infusion and also symptometrin, which is oxytocin ergometrin. And after delivery, we need to continue the iron supplementations until the iron stores are restored, even if hemoglobin is normal. So keep giving iron supplementation and then keep checking the ferritin to make sure that that's getting back up to normal. Right, so this is the last case study here. So a woman attends the antenatal day assessment unit to discuss the results of her glucose tolerance test. She's 42 years old and this is her 6th pregnancy. So she's already had previous 3 cesarean sections, 1 early miscarriage and a termination of pregnancy. All booking tests were normal, as were her 11 to 14 weeks and anomaly ultrasound scans. So she's of Indian ethnic origin, and now she's at 26 weeks. And the midwife has arranged a glucose tolerance test because of a history of type 2 diabetes. So this is what we found on examination. BMI is 31, blood pressure is 147/87, and everything else is okay. So BMI is quite high, isn't it? This is what we got in the investigation. So what are we thinking about this? Yeah, so we're thinking about gestational diabetes over here, because the 2-hour OGTT is more than 11.1. And what's the use of the urinalysis here? Because if we go back, it said that there was glucose in the urine. Do you think that if you just did a urinalysis by itself and there was sugar in there, if there was glucose in there, that you would think about gestational diabetes straight away? Probably not, because I think that for pregnant women, they probably do have glycosuria anyway. So if you take that isolated result, it's not really very useful. But with everything combined with the OGTT, then it's of some use. But if you use it by itself, it's not very useful. And so this is the management. We need to tell her about how to control her blood glucose with the multidisciplinary team. So like we talked about, the doctor and the diabetes nurse specialist and the dietitian. We can talk to her about some dietary advice and some counseling there. We can show her how to monitor her blood glucose at home and maybe some oral hypoglycemics. And then if they're repeatedly high, what do we do there? Yeah, so we'd use metformin and possibly insulin as well. Awesome, that's really